Hi, this is Holly, and my presentation is about hypermobile Ehlers-Danlos syndrome and high-risk pregnancy. I chose this topic as I was officially diagnosed with this disorder about a year ago. It is a very personal topic for me, and I am also considered a geriatric pregnancy as well, which already comes with a host of possible complications. First, what is hypermobile Ehlers-Danlos syndrome? It is an autosomal dominant genetic connective tissue disorder. Hypermobile is type 3 out of 6 and is considered the least severe of the types. However, it does still have significant complications with the musculoskeletal system. HEDS affects all connective tissue, including ligaments, tendons, and cartilage, and causes spontaneous subluxations, dislocations, and ruptures of all connective tissue. Common ailments include easy bruising, bowel disorders, and chronic widespread pain. How does EDS affect pregnancies? It may cause complications with positioning for vaginal deliveries, such as with placing the legs in the lithotomy positions or using McRoberts maneuver. Postural orthostatic tachycardia syndrome, defined as a heart rate greater than 30 beats per minute or greater than 120 beats per minute within 10 minutes of moving from a supine to an upright position. Severe POTS are recommended to have a C-section as it may exacerbate hemodynamic instability during Valsalva with vaginal delivery. You may also have aortic root dilation, which could lead to an aortic dissection, which could increase the risk of maternal fatality during vaginal labor when pushing. If previously diagnosed with aortic dilation, the patient needs an echocardiogram each trimester and may recommend a C-section. Progesterone increases laxity of the pelvic girdle, which increases instability of already loose joints. It also increases the risk of falls and hip dislocations. Higher risk of PPROM and may result in preterm birth with increased risk of fetal malpresentation, precipitous vaginal birth of less than 4 hours, and a frequency of uterine prolapse in 28 to 36% of women. Laxity of ligaments and joints may present the neonate in back-to-back or a side delivery, which for a patient without hypermobile Ehlers-Danlos syndrome would be considered a complication or impossible birth. However, HEDS allows for this type of delivery with ease. Women with HEDS are more prone to anxiety and depression and should be monitored and treated early to reduce the risk of postpartum depression. Patients with HEDS usually have been previously underdiagnosed with the disorder or have been told they have a psychological disorder and the pain is not real. Due to chronic widespread pain, the patient may become depressed with their situation. Higher risk of an episiotomy due to the easy tearing of connective tissue and skin. They have a resistance to anesthesia and local analgesia and may require higher doses to be effective. Healing requires non-tension, non-dissolvable sutures to be removed after 14 days for episiotomy to prevent the risk of dehiscence due to breakdown of the collagen. High risk of stress incontinences prior to pregnancy due to the weakened pelvic floor muscles, cystocele, or bladder distension. Pregnancy and birth add more stress to the weakened area, and the patient should perform physiological exercises such as Kegels prior to and throughout the pregnancy. Since HEDS is a dominant gene, the neonate has a 50% chance of being affected as well. Barlow and Ortolani maneuvers are used to show instability and dislocations of hips, which are evident with HEDS. These neonates will need additional joint support and may present with easy bruising and dislocations, which may be mistaken as abuse. Due to the high risk of preterm birth, the caregivers should be prepared to provide resuscitation and respiratory support at delivery. Currently, HEDS is unable to be determined by a genetic blood test and is only diagnosed by physical examination. The severity of the disorder is widely varied, and before childhood, it is difficult to diagnose the severity of the disorder as it may vary from the affected parent. In conclusion, the pregnancy and birth can be complex, but can also be safely managed with multidisciplinary teams and additional monitoring. Care should be individualized to each patient, and with advancements in medical science, it is easier to prepare for difficult outcomes. It is important for the patient and the care team to be open and honest about expectations and care to provide a healthy pregnancy and delivery.